Magandang araw, everyone. Welcome back to another episode of Usapang Presyon, a project of the Philippine Society of Hypertension. We are now at the 7th episode. Napakaraming learnings na ang ating napag-usapan. Kaya naman, please like, follow, and subscribe to our YouTube, Facebook, TikTok, and Spotify channels. I'm your host, Dr. Bimbo, a neurologist and hypertension specialist.
And I'm Dr. Benji, a nephrologist and hypertension specialist.
Today, Benji, we are leaving the brain territory. And let's go downstairs to the kidneys, your specialty, Doc Benji, the engine room of the body.
Yeah, I agree.
We often hear patients say, Doc Benji, mataas ang blood pressure ko, baka ma-stroke ako o ma-heart attack ako. But we rarely hear them say, Doc, mataas ang blood pressure ko, baka ma-dialysis ako. Today, we will bridge that gap. And hopefully, we'll talk about this in detail in this podcast about hypertension and renal or kidney health. So, let's start with the basics, Doc Benji. For our lay listeners, what is the connection? Does high blood pressure cause kidney disease or does kidney disease cause high blood pressure?
Actually, Doc Bimbo, it's a chicken and egg situation, and it's a vicious cycle. So let me explain it with two analogies. First analogy is the filter analogy. Think of the kidneys as a coffee filter. And of course, with gentle flow, they work well. But if you instill pressure, high pressure on the filter, like say a strong hose, it damages the filter, causing scarring and poor function over time. Also, the volume knob philosophy. So, the kidneys also act like a volume control for both salt and water. So, when they're damaged, what happens is there's excess salt and fluid building up. And this eventually causes an increase in the blood volume and driving the blood pressure higher.
Yeah. So, in other words, Doc Benji, if the kidneys are broken, the pressure rises. And if the pressure rises, the kidneys breaks further?
Yeah, that's right. So, in my clinic, I see a lot of CKD patients manifesting always hypertension, about 90% of my patients. It's a number one sign that you can see that the kidneys are really struggling.
Right.
Yeah.
So, Doc Benji, let's talk numbers. Patients get confused. Sometimes they see 140 over 90 millimeters of mercury in YouTube or other social media. Then they hear 120 over 80 millimeters of mercury from their doctor. For a regular person without kidney issues, what should be the goal?
Well, generally for patients with kidney disease, we follow what the guidelines would tell us. They say 140 over 90, not more than that, millimeters mercury. But if you can tolerate lower, especially for patients with high levels of protein in the urine, we usually regulate the blood pressure at 130 over 80, not just for the kidney, but also for heart protection.
And would you agree also that, okay, so first target, below 130 over 80, but if you can even tolerate it without adverse effects, you can go down to less than 120 over 80. Even better.
Yeah, that's what the authority of guidelines in kidney disease,
Right.
KDIGO,
Right.
KDIGO guidelines. They say that they found out in that study that a systolic blood pressure of less than 120 millimeters mercury translated into a better outcome. But of course, they have a caution there that they can target less than 120 over 80 if the patient can tolerate it.
Okay. So less than 120 can even be a better target for most patients if they can tolerate.
Yeah, that's what we call the aggressive BP control. And they found out that intensive control saves lives and of course they delay the need for dialysis. But there's a disclaimer, what the KDIGO guideline mentioned, you try to target less than 120 over 80 using a standardized BP measurement. And what is this, So you cannot just rush into the clinic, sit down and check your BP immediately. No? So the rule, this is a standard rule, standardized BP measurement requires the patient to have their feet flat on the floor and their back supported and stay in the room, in a quiet room for 5 minutes. And of course, they should empty their bladder. So if you don't do this, then the BP reading is falsely high. And if you treat this false number to less than 120, you may even develop a catastrophic event. And the patient might get dizzy and develop some other problems.
So in other words, Doc Benji, like for myself, for example, on the preventative side, not developing kidney complications from hypertension, which we advocate that as much as possible, if we can monitor our blood pressure 2 or 3 times, or sometimes even more, the average of your blood pressure, there will be times that will go up, but the average should be compared to less than 130/80, or even better, less than 120/80, for as long as the patient does not feel dizzy or other side effects. Important is that I think we have always emphasized, Dr. Benji, that when one checks the blood pressure, it's just like the airplane, the pilot who flies the plane, maraming checklist muna. And foremost of all, which I always teach our patients, is that you open your phone, the clock there may timer, 5 minutes, at least 5 minutes of the rest muna before you punch the blood pressure. Check your position, everything.
So that's what the essence of standardized blood pressure measurement.
And
you should do it the right
no
way.
alcohol, no
Alcohol,
coffee.
yes.
Okay, so let's get real, Doc Benji. Medicines are great, but we can't medicate a bad lifestyle, or we cannot out-prescribe, better word, a bad lifestyle. Let's talk about the Filipino diet.
That's always the problem among Asian or Filipino diet. Is always salty, no? And sodium is the enemy of the kidney.
Where should be the middle ground? How salt should it be? That's okay with the kidney, that the kidney will not be stressed too much.
Majority of Filipinos are salt sensitive. But I said that you're right that we have to discriminate which one are sensitive or not. And there are conditions, not so many, but there are some conditions that they present with salt wasting conditions. So these are the patients who don't need the salt restriction. But majority of hypertensive patients among Filipinos usually are salt sensitive and should be restricted from taking too much salt.
Okay. Like I've experimented a little myself, Doc Benji. I'm not hypertensive, but I noticed that when I eat a rather salty meal, we are in outside in a Chinese restaurant, and I check my blood pressure to my wearable blood pressure device, it goes up. But later on, it goes down. So do you think among real hypertensive who are salt sensitive, the peaking of the blood pressure after eating a salty food does not go down right away? It would be sustained a little bit more.
Especially among patients with kidney hypertension. The body holds the salt. Stays in the system longer because of the inadequate excretion of volume.
So therefore, what you mean is, for example, this is the kidney. When there is higher than what is necessary salt, it absorbs more water. And therefore, the volume inside goes up.
That's what we call... They always go together.
They go together.
They have a lot of salt. They tend to have more water retention together with the salt.
And what can you say about the opposite effect of potassium?
The potassium, on the other hand, can cause the blood pressure to go down. So the opposite.
The sodium-potassium pump.
With the sodium-potassium ATPase pump, there is always an exchange of sodium and potassium, which will facilitate entry and excretion of potassium. If there's entry of potassium, sodium goes out. So there's always an opposite direction of both your sodium and potassium.
That's why I remember when I was in, I think in Singapore, I went to one of their groceries, and I saw this potassium salt as an alternate salt. for cooking. And then I saw that it was well endorsed even by their medical society. So, what can you say about this as a potential alternate salt in
Yeah. Well, it's a good alternative, but there's a bit of caution, caveat that when you are dealing with a patient with kidney disease, be very careful. You have to closely monitor the potassium because among patients with advanced CKD, usually they have also impaired excretion of potassium. So among those patients with early CKD, then potassium salt can be alternative. Yeah.
Okay, Doc Benji, as a stroke neurologist, siguro isa kami sa mga marami nakikita na with talagang when we ask their history, nakamedicate naman sila. They're receiving 2 or even sometimes 3 drugs. And yet, nag-i-stroke pa rin.
Yes.
So, kasi di naman nila monitor,
Right.
they don't monitor it, they belong to either uncontrolled or some of them may even be resistant hypertension.
Right.
Let's talk about resistant hypertension.
Right.
What is resistant hypertension?
So I think this was already discussed very much in the previous podcasts. No? So I just reiterate the definition what resistant hypertension is. No? So ito yung blood pressure wherein the target BP is not or the BP that we get is not a target despite 3 different medications, 3 classes of medicines, and maximum doses, and one of them is a diuretic. And usually renal patients or kidney patients are also just like stroke patients. Kidney patients are also classified as one of those with resistant hypertension.
Okay. So, what do we do? What should be the approach to these cases of resistant hypertension?
Yeah.
Is there a magic pill?
Yeah. Siguro what we usually do is to check adherence muna, before we say that they are really resistant. So first thing that we have to ask is are they taking their meds? So usually the water pill, we call it diuretic. Often the patient is given a weak diuretic, meaning they are not able to achieve adequate volume control. And usually, there are better diuretics. Kasi alam lang natin, we do thiazide, loop diuretics like furosemide. But they are short-acting and they're not able to address BP control.
So, So just like, for example, I'll go straight to the losartan. If it is 50 milligrams, it doesn't cover 24 hours.
Yes.
Medyo short-acting lang siya. So the hydrochlorothiazide, as you say, medyo short-acting siya. Unlike the others like indapamide and even chlorthalidone are longer-acting.
Yes.
So even when you sleep, covered ka.
Covered, yes.
Okay.
So they say nga the game changer pa rin is, of course, giving this thiazide-like diuretics, and we also have what we call the mineralocorticoid receptor antagonist, MRA, like your spironolactone.
So it's not a different class.
It's a different class. They act on a different site in the tubules of the kidneys. So these are drugs which are very effective also in controlling blood pressure, particularly those with the resistant hypertension.
Oh, spironolactone. Wow, what a word.
Yes.
That's the one that blocks the aldosterone, right?
Yeah.
Okay.
And yes, it's, as I've said earlier, it's very effective for resistant hypertension. But again, word of caution, that for patients with kidney disease, we must watch one of the side effects of spironolactone, which is potassium retention. And high potassium can be dangerous for the heart, especially for these kinds of patients. So I think they should be monitored by the doctors and must be prescribed by the doctors and not just bought over the counter.
Okay. Yes. So we've come to the top. Doc Benji, we've covered a lot, from the filter analogy to the dangers of Mapataas and the power of spironolactone. Doc Benji, what is your final message to our viewers and listeners in this podcast?
As we always stress to our patients, the kidneys have a vital role in our system. So usually we always advise them to protect their kidneys by controlling their blood pressure. And usually,
Patients with kidney disease may be asymptomatic. Do not wait for symptoms to occur before you correct your blood pressure, because kidney disease is silent until it's late. So get your blood pressure checked regularly.
Thank you very much, Doc Benji. And that's it for the Usapang Presyon Podcast 7th episode. Share, like, follow, and subscribe to our Facebook page, TikTok, YouTube channel, and listen to our Spotify. Maraming salamat po sa inyo lahat.